Thanks for joining us for the July edition of our Caregiver Journey Webinar series. I have my DJ headphones on today because I seem to have a special talent for misplacing my earbuds, but neither here nor there. Really happy to be joined by my colleague Mary Pat Scoltock to talk about palliative care and hospice care today. Hey, Mary Pat, how are you?
Great, Matt. Thanks for having me.
Well, thanks for being here. Thanks for being
Absolutely.
here. I really appreciate it. So I'll take a quick second here to introduce Mary Pat to the group. No blushing on your part, Mary Pat, but she's a care advocate here at Carallel. She joined us this past April after a 30-year plus career in healthcare, spanning palliative care, hospice care, home health, and senior housing, senior living. So we're thrilled to have Mary Pat here with us as an expert on palliative care and hospice care. So thanks again for joining us today, Mary Pat.
Absolutely.
So as usual, a couple of housekeeping items. If you're new here, thanks for joining. A quick second on Carallel. So we're a caregiver support company. We support family caregivers in two primary ways. First and foremost, with our caregiver support line that is staffed by Mary Pat and her peers who are trained professionals and typically have either current or past personal experience as family caregivers. And they're standing by to help you by phone, by email, by chat, with whatever caregiving challenges you have on your plate on a given day. We complement that support with our digital platform called My Care Desk by Carallel, which is really a one-stop shop digital caregiving hub where you can store information, organize tasks, ask for help, keep your family and friends updated on the care of your loved one, and read lots of educational material across a wide range of caregiving topics. So that's in a nutshell what Carallel does. We make our service available through health plans and employers nationwide. The second really important piece of housekeeping, because we want this to be a conversation, is please do, as you have questions or comments or thoughts, please do share them in the chat. We'll do our best to get to them in the live session, and any that we're not able to get to, we will follow up after the call to make sure you get the answers or responses that you need to those questions. So, Mary Pat, that's the extent of the housekeeping. So we're going to get into it. And what we typically do on these sessions is start with a poll, just to gauge the room and get a sense for people's thoughts on the topic coming into the conversation. So I'm going to launch today's poll, and it's why did you join today's webinar? Pretty straightforward. You can select one of three options. Palliative care has been recommended for my loved one. Hospice has been recommended for a loved one, or I'm just curious for the future. All right, we have just about 70% of the vote in, now 80%. All right, pretty interesting here, Mary Pat. So, and I'm not sure what I would have predicted in terms of responses for this this poll, but I'm going to go ahead and close it out because we have just about all of the vote in. It looks like we're 80% I'm curious for the future.
Okay.
And 20% hospice care has been recommended for my loved one.
Okay. So
that's great, because that means people are being proactive. To me anyway, it means that people are being proactive and trying to understand what can be a very confusing topic. I don't know about you, but when I was in the midst of my caregiving journey, I was sort of I really, looking back, I could have used a conversation or two to help demystify palliative care and hospice care and understand better how they could help me and my mom and my father-in-law. So, so with that though, as we normally are, we're really trying to be focused in these conversations, Mary Pat, on the practical realities of the topic, right? Absolutely. So today that means defining at a fundamental level palliative care, hospice care, understanding the similarities because there are many, and understanding the differences because there are some key differences that we should all be aware of as caregivers. And then, of course, a couple of practical things, understanding how we pay for palliative care or hospice care.
Right.
And lastly, of course, we're gonna seed the group here with some questions to jot down and file away for when the time comes when you're considering palliative care or hospice care, or it's being recommended for
Mhm.
you and your loved one. So
Mhm.
how's that sound for you, Mary Pat?
Great, perfect.
Awesome. Well, let's do it. And why don't we start by, can you just talk a little bit, Mary Pat, about, let's tackle palliative care first. Can you
Sure.
give the audience a sense of what it is?
Yes, absolutely. And it can be very confusing because the terms can be interchanged. Hospice is that scary word that people panic when they hear it, but I'm here to tell you not to panic. And I'll tell you why. So let's start with palliative care. Palliative care is really when it's specialized medical care, excuse me, and it's focused on the relief from symptoms and improving quality of life. So maybe you have a diagnosis. It might be life-limiting or a serious illness, but you're seeking curative treatment and you're having a lot of pain or symptom management. It can be in conjunction with your curative treatment. Palliative care can be a nice adjunct. It's usually provided by a more limited, what we call interdisciplinary team. It depends on the setting. It can be provided in a hospital. It can be provided in your home. It can be provided in a nursing home, senior living. So that will depend on what the facility or location is. It can be in a palliative care clinic, but it is usually a physician. It can be a nurse, it can be an APN. Many times there's social workers and other adjunct things that connect with palliative care. So think of it as somebody who has a serious illness, maybe even life-limiting, but is still seeking curative treatment.
Okay, excellent. So got that piece.
Okay.
And the other piece you mentioned, just to reiterate, can be provided in a variety of settings, right?
Correct.
Did I hear
Yes.
you correctly on that?
Absolutely.
Okay.
Yes.
So that's palliative care.
Mhm.
What about hospice care?
Yeah.
Can
So
you give us a sense of what hospice care is?
absolutely. Hospice care, and that's where people hear that and they think they must be going to die tomorrow. And the reality is hospice is one of the best Medicare benefits we have available to us. It's really specialized for comfort and quality of life. It is when you're not seeking curative treatment anymore. So palliative care, you can still be seeking curative treatment, but you want to manage whatever this illness is throughout until the end of life. So there is, Medicare does add a life expectancy of 6 months. So what does that mean? In 6 months, if I'm still on hospice, do you kick me off? No. What that is a guidepost for our physicians and really you as a family member and potentially even a patient. If that physician would not be surprised that your loved one would die within the next 6 months, they are usually eligible for hospice. And you have to be eligible, you have to meet certain criteria. So many people think, well, yes, they have all of these things going on. They could die at any time, but they're not ready for hospice. Well, actually, they are, because hospice is, I like to describe it as really a blanket around the family and the patient. And it is really specialized caregivers that know what the disease is, how the disease is going to progress, and how to make you the most comfortable and have as little pain as possible. And then there's all the psychosocial dynamics of it, of conversations that you maybe want to have, goals that you want to achieve. Hospice can do all of those things in conjunction with your care team.
Okay. I appreciate the comprehensive definitions there, and my head's spinning because there are, hearing you talk about them, there are a lot of similarities, right? In terms of, I guess chief among them, the way I perceived what you were saying is the focus of each on symptom relief and quality of life. So can you, I guess a question that may be a silly one to you, but can people be using or leveraging palliative care and hospice care at the same time?
Well, yes and no. So this is where it gets confusing, because when you think of the word palliative, it's palliation, it's making you feel better. So is part of hospice care palliative care? Yes, it is. but palliative care isn't hospice. So I know that's confusing. You really think about it, one is paid for through Medicare Part B and one is paid through Medicare Part A. And think of palliative care as really the kind of partnering with you through understanding what the illness is and helping you figure out what kind of course of treatment you might want. Hospice is more related when you're kind of done with treatment. Now, I say that, and if you're on hospice and a new treatment becomes available, or you decide, I want to go to the hospital and have this surgery, you can do that. You can come off hospice. It's a very fluid benefit. You can go off hospice, get some treatment, come back onto hospice. So it is a very fluid benefit. And I think the biggest thing is to advocate, to ask for these consults to see, because our physicians have, they're here to save us and make us better. They don't really like to have these conversations about, I can't help you anymore. I don't know what else there is to do. And you really want the experts that know how to walk along this journey with you, to be there by your side.
Sure. Okay. So, and I can sense this is all making sense to me, but I can sense, as you mentioned, where I'm reliving some of the potential confusion between the two, right? As I hear you talking. So let's just reset on the similarities, because I think those are pretty clear. First and foremost, both are focused on quality of life, relief from symptoms, pain management, etc. Both are delivered by an interdisciplinary team, albeit there may be sort of difference in sizes. Hospice team may be a little bit more comprehensive.
Correct.
Okay. And then both can be delivered in a variety of settings. So, for instance, my father-in-law had both palliative care and hospice care here in our home, whereas my mother had her hospice care in the community where she was living. So I get that piece. And then lastly, so are the assessments similar? Is it one assessment or consult, as you mentioned, to sort of to get on to palliative care and hospice care, or are they discrete, separate assessments?
They can be, it depends on who's doing the assessment, but let's say that you're in a community setting and somebody's mentioned palliative care. You can call for an assessment, ask them to come out and speak with you and just talk about what's going on. And ideally what that practitioner does is talk to you about both programs. And many times we having worked in hospice and palliative care for many years, we would get a call for palliative care. But as we started to talk to the patient and the family, realized, you know what, they're truly eligible for hospice. They just don't know what it is or are afraid of it. So I always tell people, you can start with palliative medicine. What you'll find out, if you're really eligible for hospice and you really need hospice, you will not be satisfied with palliative care, because it's not as many touches, it's not as much interaction. With hospice, you have a full team, a nurse, a certified nursing aide, a social worker, a chaplain, volunteers. You can get music, massage, pet therapy. So you're more involved with that care team, where palliative care is more of a consult. Think about going to your cardiologist for a consult. It's more of a consultative, maybe you talk to them every 3 or 4 weeks. Some palliative care programs will say we can only come once every 6 weeks, and you can call us in between. So it's just, does that help? I don't want to.
Yeah, it does. It does. And I would imagine it's type of thing where it's difficult to generalize, because, in my family's experience, we had a truly wonderful experience with palliative care with my father-in-law, and frankly had us, at a certain point in his disease progression, we were thinking, man, we really should have gotten engaged with palliative care sooner. Just because we really, a lot of it was frankly driven by the person. Our palliative care nurse, in our case, was just a wonderful security blanket for us. And when we transitioned to hospice, it was it was an adjustment, I guess, right? When we were at a time when we're exceedingly vulnerable, and just it was, you know, a
Absolutely.
scary time and all of that. But
It can be,
um,
yes.
yeah, okay, so you're doing a fantastic job of sort of defining the two
Mhm.
and then talking about the similarities. Let's talk about the differences. So
Sure.
the main difference, not there's a few key differences.
Mhm.
The first difference, I shouldn't say main, but the first difference that pops into my head is um, is sort of uh, the fact that palliative care can be provided or accessed in conjunction with curative care. So things to
Right.
actually solve problems, right?
Correct. Correct.
Am I understanding that correctly?
Yes, that's
Okay.
absolutely correct.
Okay. Whereas hospice can't. But to your point, and it's worth underscoring,
Mhm.
there's flexibility. It seems like the way you're describing.
There
If
is.
if you're on hospice and a for in some way a new treatment
Mhm.
or something becomes available that is quote unquote curative and you'd like to try it, you can go off hospice and
Absolutely.
pursue that. Correct. Okay.
Absolutely.
Uh,
And this is a good time to interject, Matt, that many people think once you go on hospice, you can never go to the doctor, you can never go to the hospital, you'll never get an antibiotic, you'll never have physical therapy, and all of those things are myths. You absolutely, you could suffer from lung cancer and fall on the ice and slip and break your wrist. Well, yes, you're going to go to the doctor, and you might go to the hospital, and you might have surgery.
right.
So many times we can get an infection or a urinary tract infection or an upper respiratory infection, and you need antibiotics. You don't have to go off hospice to have
Hmm.
antibiotics. Sometimes
Hmm.
a patient is struggling with something that's part of and very important to them. Like, I want to be able to get out of my house and sit on the porch, and I'm having a hard time ambulating. So we will call in a physical therapy consult. It's
Hmm.
not like what you would have in the outpatient world, where you're going to physical therapy 3 times a week, but it is an opportunity to help you achieve whatever goals, what's important to you during this part of your life.
Okay. Okay. That's helpful. So the other another key difference is sort
Mhm.
of the timing of all of this.
Yes.
And I just want to sort of, and it's been mentioned a couple of times just because you've been so comprehensive in your comments, but worth mentioning certainly. So palliative care can be accessed, can be started uh, at or near the start of an illness or
Hmm.
at the time of diagnosis, right?
Hmm.
And
Absolutely.
hospice care cannot. Hospice care, I guess I'm asking, can you talk a little bit more about the 6 month
Yeah.
sort of, I guess, 6 month sort of benchmark to be
Yeah.
approved for hospice?
Yes, absolutely. So I like to I don't want that to ever confuse anybody or have them really hang on to that, because I've seen people on hospice for years. They are very slowly declining, and sometimes folks will graduate. We called it graduate off of hospice, and then we would transition them from hospice to palliative care. And
Hmm.
inevitably, if they have a life-altering, serious illness, life end of life kind of illness, they will progress and need that hospice care again. So again, the fluidity. The 6 month
Hmm.
mark that Medicare puts in place is really, do you think that this person might die from any of these diseases that they're struggling with in the next 6 months? And if you think that's a possibility, physician,
Hmm.
then they're probably eligible for hospice. And then there
Hmm.
is an eligibility process, and it's Medicare, and you just can't call up and say, hey, I'd like hospice. You have to be eligible, right?
Hmm.
So the disease has certain criteria. And many times, my father, I've also had personal experience, told us to call hospice, and he lived for 10 more days. And we should have, in retrospect, I wasn't in hospice at the time, he should have been on hospice from the beginning of his cancer treatment.
Hmm.
We should have started him with palliative, and we just didn't know. My mother, on the other hand, went on hospice, was on hospice for 2 months, and she graduated. They
Hmm.
really helped her get her cardiac illness under control and managed, and
Hmm.
she just got better. Now she will go on hospice again when this progresses.
Hmm.
So it again, it can be very fluid, and it really shouldn't be just for the last 2 or 3 days of life. I think
Hmm.
one of the things you and I talked about with your experience is many times people don't want to come off of palliative care because they've connected with their primary
Hmm.
caregiver, and they have a relationship with, and that is hard to give that up. Well, it's
Hmm.
also hard for the hospice team if they've only got 2 or 3 days or a week with the patient and the family.
Hmm.
So the
Hmm.
whole idea about this care is that it's really a partnership. It's really walking the journey. It's more about us finding out, what is it that you need? How can we manage your pain? How can we manage your symptoms? What
Hmm.
does your family dynamics? Maybe you haven't talked to your daughter for 20 years and you've got to deal with that. We're helping you with all of that. That's much easier to do if we have time with you. So that's
Yeah.
the other reason for kind of that 6-month period.
Right, right. And so there's a couple of things I want to respond to there because
Yeah.
you're talking about your personal experience with your mom and your father. My father-in-law was on hospice for 27 months.
Hmm. Yeah.
Um, and uh, uh, it was, they were just helpful throughout in a variety of different ways, but it was just infinitely longer than any of us expected, right?
Expected.
And
Sure.
when it was first suggested that he go on hospice, it was
Hmm.
kind of oh man, we're
A
not
shock.
ready to
Yeah.
say
Right.
goodbye.
Hmm.
But it was 27 months. In contrast, my mom was 6 days,
Hmm.
right? So the in retrospect, and there's so much
Yeah.
armchair quarterbacking and second guessing
Right.
we do of ourselves as caregivers. But my mom just passed away in April, and I've been kicking myself. I should have, a
Yeah.
lot of me feels like I wish I would have advocated for hospice
Hmm.
sooner.
Hmm.
There were other factors certainly, but the other piece is that I was going to come back to on the relationship piece, where
Right.
we have the ability to advocate as caregivers, right? So
Absolutely.
if in a case like we had with my family and palliative care for my father-in-law, where we really, really appreciated the people that were providing the palliative care for us, for him.
Hmm. Hmm.
Um, if there wasn't a fit when we transitioned to hospice, we still have recourse as caregivers. We can advocate for
Absolutely.
a person or people that we for whatever reason we feel like we'll be better able to connect with and
Right.
to. Is that correct?
Absolutely. That is
Okay.
absolutely correct. And I highly recommend that if it's not working, talk to your social worker, talk to the hospice care, because every team has a manager.
Yeah.
And sometimes personalities just don't jive.
Right.
My mom did not want a male CNA. And they were
Yeah.
like, okay, she's 94 years old. That's just not going to work for her.
Yeah.
And sometimes, depending upon the setting, everyone has personalities, right? And of course,
Hmm.
folks that are in hospice are trained, but sometimes it's just not a right fit for
Yeah.
whatever the reason is, and you've got to call and say, you know what, this isn't working. And sometimes it's a matter of a conversation, and the nurse or the CNA or the social worker or the chaplain doesn't realize, oh, I thought they wanted me to do that, and they don't.
Hmm. Yeah.
So as a caregiver, advocating is very, very important, and don't be afraid to do it.
Right.
You're not going to hurt anybody's feelings. No one's going to get in trouble. Really, it's very much a part. This is a journey that staff is walking with you on, and it's a very important. We celebrate the birth of life, and we need to do the same thing when we're coming to the end of our life. And if something doesn't seem right or feel right, pick up the phone and call. Absolutely.
Absolutely. Yeah. Okay. And that's a common thread on these webinars. So we have 4 minutes left,
Mhm.
4.5 or so. It's two really important things. First and foremost, can we have a minute on how do we pay for, how are
Yeah.
these paid for?
Right.
You mentioned the hospice benefit for Medicare.
Mhm.
What about palliative care? How do we pay for them?
Yeah, palliative care is typically paid through Medicare Part B, so it's just like when you go to a specialist. Whatever that charge is, there might be a copay. Many palliative care practices are in conjunction with hospice, and many of them are not-for-profit, and they have an ability to do a sliding scale. So again, don't be afraid to ask. Hospice is fully covered under Medicare Part A. Everything that is related to the hospice diagnosis is covered. So it might be medication, it might be supplies, it could be a hospital bed, it could be a wheelchair. Anything that you're being treated for that isn't related to your hospice will go through your insurance just the way it always did.
Okay.
So yeah.
Okay, very helpful. So lastly, in the last few minutes, I wanted to shift gears slightly and give the audience here a sense of some questions that are worthwhile to ask when either palliative or hospice are recommended, or you're considering them yourselves. Better yet. So, and a number of them are related to things we've just been talking about in the last couple of minutes. So, what evaluations do I need, right, or does my loved one need to determine eligibility? These are, that's a key question to ask early on, obviously. If you're thinking about, without it being recommended, if you're thinking proactively about palliative or hospice, what will my loved one's insurance cover? Again, we just talked about that, Mary Pat, you just covered. So oftentimes we recommend reaching out to the insurance provider to ask the question proactively, and the same, that certainly applies here. What documentation will we need, right? That's always a helpful question to ask.
Sure.
And then, of course, we were just talking about care team and advocating if something's not working. But it's worth asking the question. And this is another thing that I wish we did in our family situation, was like, because we didn't know, we weren't necessarily comfortable from the start advocating for ourselves, right? So ask the question: do we have a say in who the care team is?
You absolutely do.
Yeah, and then we talked about sort of the 6-month benchmark for hospice. So hopefully people have a better understanding for that now. A really important question for those people with a loved one living in skilled nursing or rehab situation. It's a really important question. Correct me if I'm wrong, Mary Pat, to ask what, if anything, will going on hospice do to the cost of that stay in the skilled nursing facility. Is that correct?
Yes. So, and I also didn't mention Medicaid also covers hospice and hospice benefits. Medicaid actually will pay for room and board. So if you are Medicare and Medicaid certified, you will actually pay for room and board. If you're in a rehab getting Med A rehab, maybe a broken hip, Medicare is paying for that stay. If you then go on hospice and want to stay in that skilled nursing, you would then have to pay for a room and board. And the facilities are really good about, helping you get as much of your rehab as available and then transitioning to, and also helping people apply for Medicaid once funds are running out. So you do have to understand that it is the care team that's coming in to wherever you're at, the supplies, but the actual room and board, just like if you're living in an apartment or you're living in a senior living, that is still the patient and family's responsibility. Okay.
Mary Pat, time flies when we're having fun.
Wow.
Looking at it's bottom of the hour here. So thank you very much for joining us.
Absolutely.
Audience, if you do have questions, I see a few that we need to get to after the call, but do please send me an email or just respond to your confirmation for this session. Those do come directly into my inbox. We'll answer those. Hope you all can join us for our August edition. It's happening August 25th. I'll be joined by the Chief Executive Officer of the Caregiver Action Network, John Shaw, and we'll be talking about caring for a loved one who refuses help. So hope you can join us then. But Mary Pat, thank you so much. And thank you everybody for joining us today. Really, really appreciate it. Take care.
Thanks, Matt.